everybody. Welcome. My name is Jennifer Falk. I'm the Director of Development over at MS Views and News, and we're really happy that so many of you are joining us tonight for this special event, and that you'll be participating in this program and hopefully the whole series. This is a 4-part series. For anyone that's new and hasn't joined us before, we are MS Views and News. I'll give you a little bit of background about the organization, and I apologize, my dog is barking, of course. But MS Views and News is a nonprofit organization dedicated to the global collection and distribution of information concerning multiple sclerosis. Through partnering relationships, MS Views and News provides education, advocacy, services to empower and enhance the quality of life for all people impacted by multiple sclerosis. So before we go any further, I definitely want to pause and give a sincere thanks to our supporters tonight, the supporters of this program, and for recognizing the value of tonight's program. Bristol Myers Squibb, Biogen, and Novartis, we thank you so much for the support of this program. And tonight's program, we're very excited to bring race, culture, and community while living with multiple sclerosis to you. It's been a complete honor and inspiration, both personally and as an organization, to have developed this program and this project with Sheila Thorne. And Sheila's here with us right now. She's going to be presenting this very inspirational and powerful presentation. And I'd love to give you some background on Sheila. Sheila Thorne is recognized as one of the nation's leading experts in multicultural healthcare and cultural competency in healthcare delivery. Sheila Thorne has spent almost 3 decades designing health marketing, media, and health education programs for racially diverse populations with a commitment to raise awareness of the need to eliminate health disparities and distribute culturally relevant health education. And that's our goal for tonight as well. So Sheila, before I pass this over to you, I just want to remind everyone you do have the ability to write in that question box. And we welcome you, Sheila. Thank you so much.
Thank you so much, Jennifer. It is a pleasure and an honor to be here. I was thinking earlier today about how you and I started talking about this last year. And then you and I and Stuart got together, and we very much saw that this was going to be an important program. And I am honored to share with you what I have learned on my journey. And clearly the topic is near and dear to my heart. So thank you again for this opportunity. Folks that are on the line, warm greetings to all of you who have joined us this evening. And I hope that it will be not only informative, but inspirational and motivational, because we are in a state right now in this country where we have to give much more need and interest into race, community, and culture, and specifically about how those 3 things impact living with multiple sclerosis. So now we can talk about this because it clearly is top of mind. I like to start with a melting pot because that's what somebody coined the phrase decades ago, and they called America a melting pot. But that's really not true, because that would mean that all groups come here and they are all harmoniously joined together and become one culture. We aspire to be a melting pot, but we're not quite there yet. Every group comes here and tenaciously holds on to its language, its history, its heritage, and its culture while it makes up being a part of the whole. We are all grateful and thankful to be American, but we also have racial and ethnic pride. So we are a mosaic, a patchwork quilt. Some have even called it a salad bowl, where each one of these groups makes up being a part of the whole. Next slide. But let's think about it for a moment. We are all immigrants. Sometimes we forget that, but clearly, probably you came here from another country, you, your parents, or your grandparents. Perhaps your ancestors came here over on the Mayflower and landed at Plymouth Rock. Or maybe your great-great-grandparents came through Ellis Island with 12 million other people at the turn of the century. Or maybe your family just landed 20 or 30 years ago at JFK. Or maybe like my ancestors, people of African descent, came here in slave ships. And that situation of slavery has stayed with this group. And you were deposited, these slaves were deposited in Virginia in 1619, almost 400 years ago. Next slide. So clearly we are all immigrants. But let's get some terms defined here before we go any further. And that's that word race. People hear that word and they get very nervous. They get very uncomfortable. But let me put you at ease. The term race is not real. There's nothing scientific or biological about race. It's a man-made invention. All that means is physical traits, the color of my skin, the shape of my eyes, the texture of my hair, my body image. That's what race is about. Unfortunately, people group people by race and assign some stereotypes to them. So race is not the appropriate way of talking about these groups. The more correct term is ethnicity, how you group people by national origin, by language, by culture, and by religion. So you'll often see race/ethnicity when it's written in text or in publications. That's the correct way of referring to groups and how we categorize people. Culture, you learn that. You learn that from your family. You learn that from your community. You learn that from your national group. What's acceptable, what's appropriate, what's respectful, and you transmit that. It's a generational thing. Culture impacts how you think, impacts how you act. But now let's put things in better perspective. If the world were a village of 100 people, what would it look like? 82 of the 100 would be people of color, 74 of the 82 would be Asian, and only 9 would speak English. So that's an image of the global village. Would you like to live in that village? Would you be safe in that village? Could you find a job in that village? Well, clearly, we are a microcosm of that global village. And you see, we're a mosaic. We come from different religions, different cultures, different skin textures. That's what makes this country great. It's diversity. But sometimes it's the diversity that causes us the most challenges. So if we're going to talk about race, culture, and community, you need to learn a few things about these races and about these ethnicities and about these cultures. Next slide. Even language is diversity. There's no official language in this country. Even though English is the predominant language spoken, there are four other languages that are spoken. In fact, 200 of those 500 languages are spoken in the state of California. Then there are dialects: Jamaican Patois, Haitian Creole, Brazilian Colunga, Cubano Spanish, African American Ebonics. So we are diverse racially, ethnically, and linguistically. Next. Millennials, 74 million strong, are now 87 million strong, are more diverse, the most diverse generation in American society. Next slide. And be careful when you use that term minority. That term has become pejorative. It's become synonymous with uninsured, uneducated, poor, people of color. It's marginalizing. It makes one feel inferior. And as I travel around the country talking and working with many of these groups, many people don't like that term, and it might be even offensive to some. Next slide. The more appropriate expression would be people of color. And that has nothing to do with the pigmentation of your skin. It has more to do with shared experiences of Black, Latino, Asian, and Native American populations. And they've even added I, so it's BIPOC now, Black, Indigenous people of color. Frames it more positively than using the term minority. And here's where it got started in terms of the demographics shifting. 2012 was the first time babies of color outnumbered the births of white babies. Next slide. And when we go even further, when we look at children under the age of 5, half of them are Black, Hispanic, or Asian. When I started using this slide, the number was something like 40%. Now it's up to 47 and 50%. Look at these adolescents, teenagers. By the time they reach their 30s, there will be no racial or ethnic majority population in this country. Next slide. Other end of the spectrum, our seniors, our elders. Clearly, we have the aging of America, but we also have the browning of America. Clearly, the Latino community outnumbers all in terms of the aging process, as well as the other people of color. Next slide. Let's take this group, Blacks and African Americans. Now, this group we have the most clinical information on. We have the most information in terms of their habits and lifestyle, almost 48 million strong. But the terms Black and African American are not the same. Black is anyone of African heritage from anywhere in this world. African American is if you are of African heritage born in this country. We use them interchangeably, but they're not the same. Even in this group, you have Caribbean, you have African, you have Haitian, you have a number of different groups. Let's take a look at this group. Now the largest so-called minority population. Next slide. And this group has reached almost 60 million. But is Hispanic a race or an ethnicity? Well, it's an ethnicity. It's someone who speaks Spanish, who comes from that part of the world, and this was given to this group. They didn't select that term. It was imposed upon them by the Census Bureau. Next slide. But even within this group, there's great diversity. 4 countries are at the top of the list: Mexico, Puerto Rico, Salvador, and Cuba. Those are the largest countries of origin within the Hispanic population. The others are smaller, Central and South American. So more diversity within than between groups. Next slide. And where are they in this country? Obviously, these are the states where you'll find the largest numbers of Hispanic Latinos. And there are some states where it's growing: Kansas, Nebraska, Oregon, New Hampshire. Who would have thunk? These groups are moving all around the country in searching of jobs and better education and better life. Next slide. And language is the common thread, but culture is different. So as more and more becoming a part of the American culture, they're speaking English more and more, but they do speak both languages. So when we talk to these groups, there are multi-generations in one household. So you should be able to have materials in Spanish and in English. The elderly members may be more fluent in Spanish. The younger ones may be more fluent in English, but language is a common thread. Next slide. Now, this is the smallest of all of the racial groups in this country, but the fastest growing. If you checked Asian on the census, you could be any one of 30 or 40 different groups. And you can see the list of these groups as they're given, all different linguistically, historically, culture, heritage, all very different, very diverse, very rich cultures. Next slide. 6 of the largest groups, you'll find 80%, 85% of the Asian population: Chinese, Indian, Filipino, Vietnamese, Korean, Japanese. Where I live in New Jersey, it's a large group of Korean community. And I love eating in their restaurants. I have many Korean friends, and it's a culture that has a rich history and clearly a very politically divisive history as well, but a very warm culture, as all of the others are. But again, extremely diverse. Next slide. And here's where they are. Ethnic enclaves: Blacks, Latinos, and Asians sometimes congregate in the same communities because they have so many interests and similar lifestyles. So that's where they are in the country. Next slide. And I also put this slide on because many of those in the Asian community, geographically, their origins were very together. So they have very similar celebrations, very similar habits, and very similar religious ideas. And we're now in the midst of celebrating the Chinese New Year, and it's the year of the ox. You need to look up on the internet what these animals depict for each year in the lunar calendar of the Asian community. Fascinating history, but we're now celebrating their cultures. Next slide. And let's not forget about our indigenous populations: Native American Indians, Alaska Natives, Hawaii Natives, Pacific Islanders. They were here before all of us. Unless you're a true-blooded Native American Indian, you're an immigrant. They were here first. That's part of the American mosaic. Next slide. And the community of Native American Indians is huge in this country. Many people don't know that. There are over 570 federally recognized tribes. There are about 70 state-recognized tribes. And unfortunately, this group is suffering tremendously with COVID-19, and we're going to talk about that a little later. But that's where the tribes are located. So rich culture, rich habits, rich history, and part of the American mosaic and part of the American community. Next slide. Here's a group that you don't hear about that often. People from the MENA region, Middle East, North Africa. Unfortunately, there hasn't been a designation on the census for them until recently. There are about 6 million in this country. Again, religion, language, history, all very different, a very important part. So they're not Caucasian, but since there may not be a designation on the census for them, they sometimes check Caucasian, or they may write in the country they come from. So we're not quite confirmed about the number that these groups represent in America. Next slide. So then the question is, which one do I use? Is it African American or Black? Is it Hispanic, Latino, or Latinx? Is it Asian American, or Oriental? I certainly hope it's not Oriental. That's food, furniture, and rugs. So clearly, we have to be clear about what we call these groups, because many of them may not want to be called what you're comfortable with, but they have to self-identify. And then white or Caucasian, where did that come from? Next slide. Well, it's this gentleman's fault, Dr. Blumenbach, an anthropologist. He studied skulls and jaws and eye sockets. He was trying to figure out how to divide up humankind. And the one skull he liked the best came from the Caucasus, which is near Russia. He thought it was the most beautiful skull he had ever seen. So he arbitrarily took that and said all Europeans are now going to be called Caucasian. A scientifically sounding term, but completely random. Next slide. And what about people who check 2 or 3 boxes on the census? What about that community? What about those races and their culture? Well, this family, the husband, his father is African-American, his mother's Cuban. The wife, her father is white, her mother is Filipino. So what are these 3 beautiful girls? If I didn't tell you that history, you might think they're African-American, maybe they're Latino. The point is, they are what they say they are. Next slide. And here are some of the famous multis. Derek Jeter, father African-American, mother German. The Rock, Dwight Johnson, father Black Nova Scotian, mother Samoan. Halle Berry, father African-American, mother white. Tiger Woods, he calls himself Cablinasian, Caucasian, Black, and Asian. A lot of derivations there. Lenny Kravitz, a musician, father Jewish, mother African-American. Our former president, Nigerian and mother of English heritage, and now our new vice president, African-American, or Caribbean, and Asian Indian. Wow. So these multicultural populations are driving the communities. And boy, look what happened here. Father is Australian, mother is Jamaican. They had 3 children, and then they had twins. That's happening more and more because of intermarriage, intercultural, biracial. So when you talk about race, community, and culture, you're talking about a huge mixture, a mosaic of different cultures and different countries of origin, different ethnicities. All of that goes into what it's like living in community. And we'll talk later about living with multiple sclerosis. Next slide. So we've reached a tipping point. When I was growing up, my mother couldn't find a doll that looked like me for me to play with, but now you can. So even the consumer world is looking at diversity and how to reflect the population. Dora the Explorer, the most precocious Latina bilingual in the world, very popular among children. So we have reached the tipping point. Next slide. And don't think that these groups are poor. People sometimes put them in the category of being poor, uninsured. Well, they may not have stock portfolios. They may not have a lot of credit cards, but they have cold cash. And many times the companies and the organizations who reach out to them call them super consumers because they'll spend money when it means taking care of their children or senior relatives. Next slide. Some think that maybe they're illiterate, they're uneducated. Well, there may be some pockets of that, but looking at this slide, many have a high school diploma, some have even bachelor's degrees, and some have even gone on for advanced degrees. So the question is, do you lump everybody in one bucket? No, you have to really understand community and culture and how it drives behavior. Next slide. Health insurance, clearly that's of interest to us, being that we are living with conditions that need health care. The middle bars, there are 14% of Blacks that have no insurance. But guess what? There are 86% who do. There are 25% of Latinos that don't have insurance, but there's 75% who do. And it's all employer sponsored. So these are working people. So income, education, and health insurance, we have just dispelled some of the common myths about these groups. Next slide. But as much as they've advanced educationally, politically, and economically, the health profile has remained the same. People of color get sick more frequently, they're screened for illness less often, they're diagnosed later, they're treated less aggressively, and they're buried earlier. This, unfortunately, is the profile of people of color. It has been persistent and pervasive. We've made progress in some areas, but not enough. Next slide. So we have disparities. We have differences in health outcomes. We have differences in healthcare access. Those are the two kinds of disparities that are predominantly in communities of color. Big gaps between communities of color and the white population. Well, why does this exist? Next slide. Especially in these diseases. And I've added MS to this because, as we'll learn later, there are disparities there as well. And sometimes the disparities can't even be measured because they haven't been studied. But here are the main disparities that are underlying conditions that impact race and community. Next slide. And certainly this latest data shows that that's even growing in the United States, twice as many as was formerly understood. Why is that? Well, we need to do more studies. We need to find out why this is happening. Next slide. And the worldwide prevalence, you see, the highest prevalence, as you can see, is in North America. And clearly, there must be reasons for that. We need to have more research. We need to have more people of color involved in the conversation and in the research to figure that out so that people living with multiple sclerosis can get what they need in terms of treatment and the most safe and efficacious treatment. So this slide says that there's a new study that talks about MS being higher in certain populations in certain geographic areas. That's a clear indicator that we have to focus on eliminating these disparities and how help people with MS live with this condition. Next slide. Clearly, the data suggests that the data are lacking, the mortality trends are lacking, but we know that it's unequal in people of color. We know that there's more incidence. We know that intuitively, but we need to document it scientifically so that we know exactly who we need to help and what we need to do to help them. We need the evidence so that these factors can be clearly a part of a provider's framework as well as the community who may be living with MS. Next slide. Here are some of the things that are clearly apparent in the research. People of color get the disease earlier. The symptoms are more severe. There's faster progression, more disabilities, greater relapse rate. I think this shows us that we need to focus on these communities so that we can do a better job of treatment and helping people to manage the disease. Next slide. But the real reason, or I should say a significant reasons for the health disparities are what's not seen. People point to health insurance and poverty as the big factors as to why these disparities exist. But look at what's underneath the water. Stress, racism, poor working conditions, bad neighborhoods, low unemployment, low literacy. All of those are what we call social determinants, things that drive outcomes and incidents even more than insurance and poverty. Next slide. And when you look at the percentage of these social determinants and how they impact health, again, social and economic factors stand out as the greatest percentage affecting one's health. Where you live, not necessarily your DNA code, but your zip code. Next slide. And here they are spread out. Economic stability, neighborhood and physical environment, education, food, community and social context, healthcare system. All of those things drive health outcomes. And notice that line in the middle, racism and discrimination are significant factors that impact living with MS in community and among different races. Next slide. And the percentage of these factors is high, 40%, the impact of social determinants of health: education, job status, family support, income, and community safety. Clearly, these are factors that we have to see and acknowledge and address if we're going to be successful in helping people living with MS. Next slide. Here's a good friend of mine, Dr. Kamara Phyllis Jones, who wrote a book called How Racism Makes People Sick. And we think of racism as a pathology, as hateful acts, ethnic slurs, but it's really a system of power. Based on how I look, I can either be denied a job, denied a good house, or a best education, solely on how people interpret the way I look. That's power. And the so-called majority population has that power over us. They either assign value to me or they assign no value to me. So that's something that we have to acknowledge. We can't necessarily erase it, but we have to acknowledge it. Next slide. And clearly, when the pandemic hit last year, many of my colleagues all knew that it was going to hit our populations the worst. So Dr. Fauci was testifying in Congress, and they wanted to know, well, why do Blacks and Latinos and Asians have more incidents, infections, and death? He pointed to racism that these groups have been suffering under for a very long time. So it goes back to those social determinants. Next slide. And racism has an impact because it exacerbates stress. Daily, unending encounters with bias and discrimination leads to all kinds of things that will definitely impact the condition that people are living with in a health perspective. This is something that is apparent, and it's been documented in the literature as well. Stress, how to manage stress. Next slide. And it's not just the blatant forms of racism, it's the daily, what we call microaggressions, the things that people say and do about how you look, how you dress, how you talk. They will often have an impact or a response that clearly is stressful. Next slide. And it's also been linked to other conditions as well, heart disease being one of them for African Americans. So this is really nothing new. But the question is, how does it impact people living with MS? Next slide. And this particular kind of stress has now been becoming more apparent in the last year. They call it race-based traumatic stress. It's like pressing your foot on the gas and never letting up. And this physician, whom I'm very friendly with, Dr. Bailey, a forensic psychiatrist, told me there are more people of color suffering from PTSD in America today who have never been on the battlefield. That's daunting. That's disturbing. Next slide. And many in the MS community think that it is a factor that exacerbates or makes their condition worse. So in terms of the treatment and in addressing and living with MS, we have to acknowledge or help figure out ways to diminish or mitigate stress. Next slide. And stress, what it does to the body is not only an emotional and psychological reaction, it's a biological reaction. One physician told me, when you have to eat and keep the stress internally, it doesn't make your organs work very well. And it certainly does debilitating things to your immune system as well. So stress is critical in terms of living with MS and how to minimize or mitigate that stress. Racially motivated stress. Next slide. But these disparities are not new. We've known about them for a long time. Margaret Heckler, who was then part of the Health, Education, and Welfare Division of the federal government, documented it. 1985, almost 40-some years ago, 9 volumes, 3,000 pages. The conclusion was people of color in this country receive less than optimal care. What happened out of this study was they set up the federal agency of the Office of Minority Health and the state offices of minority health, which are charged with the task of focusing on improving the quality and longevity of life of all Americans, but specifically Black and minority populations. Next slide. Fast forward to 2002, and there was a study, Congress commissioned a study by the National Academies of Medicine, the National Academy of Sciences, the Institute of Medicine, the Unequal Treatment Report. But this was different. This survey insured people of color, and they still concluded that people of color in this country receive less than quality care. And the title of that study was Unequal Treatment. That's the language used in civil rights legislation, confronting racial and ethnic disparities in health. I attended some of the sessions of that forum. There were heated debates among physicians of all races and ethnicities as to how this could happen in our country, but it exists. People of color, less than optimal care. Next slide. And fast forward to 2015, another study. Representative Kelly from the great state of Illinois did another study. The same results. The inequities, the health inequalities are pervasive and persistent in communities of color. That's why we have to learn about race, culture, and community. Next slide. And even in 2020, last year, this article came out that doctors believe that Black people don't feel pain. It's being taught in medical school. Black children, Black adults, less likely to receive treatment for their pain, often dismissed because of their pain. Doesn't make it, they're not considered, even when opioids would be necessary, because physicians often think that Black and Latino and Asian people become more addicted easily. Nothing could be further from the truth. Next slide. They even think that our skin is different, so we don't feel pain the same way. And this was a study of 222 white medical students. So doctors are not racist, but they still hold some racist beliefs because it's woven in the fabric of our country. And so if you're living with a chronic disease like MS, that's something that physicians, providers, healthcare facilities need to be aware of, how to dispel those myths and misperceptions so we can get the proper care. Next slide. So the movement of cultural competency has been on now for probably more than 2 decades. What does that mean, cultural competency? We know cultural sensitivity. It means that you have to understand and respect difference, but not just that. You have to respond appropriately. You know there's a difference, but how do you respond with your treatment, with your behavior, with your attitudes? That's what competency is about. It's action-oriented. Next slide. So the American Medical Association sent this 300-page book to its members, a cultural competence continuum, because they realized that culture plays a significant factor in not only how people are diagnosed, how soon they're diagnosed, but how they're treated. Next slide. And I urge you, if you don't know about this book, that you need to read about this book, Medical Apartheid by Harriet Washington. It traces medical experimentation on Black Americans from colonial times to the present. We know about recent incidences in our lifetime, but she goes back even further. So this is deeply woven in the history, medical history of this country. Next slide. And I had the pleasure of meeting these two OBGYN oncologists at Harvard who have traced race, health, and medicine from slavery to the dawn of the millennium. Dr. Michael Bird and Linda Clayton, a husband and wife, who are now at Meharry, but who are medical historians. And these books really show and understand and explain the origin of healthcare disparities. Hit it again. And they have something they call the slave health deficit that they talk about in their books, that these populations have suffered from horrific environmental conditions, overwork, poor nutrition, and that has generationally impacted people of African descent. Next slide. And not only those egregious methods of torture and of abuse, but it's the environment that we live in today. It's the culture that we live in. What if you were of color and you walked down the street and you saw signs of this nature? What would that do to you? How would you feel? Certainly that has impacted people of color in this country. This kind of discrimination that's legitimized, enforced, enshrined, and supported. Well, today we're glad we don't see those signs anymore, but is the mental state still there? Next slide. I thought I'd tell you about a couple of instances where this egregious behavior has impacted people of color. This gentleman, J. Marion Sims, who's touted to be the father of gynecology, almost everything we know about gynecology and female reproductive system is from this Dr. Sims. He actually bought slaves and experimented on them in a makeshift clinic in his backyard. In fact, on one Black slave he brought, he operated on her 34 times without anesthesia. Now you see where that idea came from about Blacks don't suffer pain. Well, people say, was he a monster or was he a genius? Well, I leave it to you to decide. But here's what happened in New York. Next slide. There's a statue of him right across the street from the New York Academy of Medicine, honoring him as the father of gynecology. Next slide. But what the community did when they found out about him, they had a demonstration, a protest in front of this statue, demanding that it be torn down. Pretty dramatic demonstration by these women who really see Dr. Sims as a monster. So what happened? Next slide. The slide, it came down. They took the statue down. It's now positioned in a cemetery in Queens. Next slide. And here's an artist interpretation of what these white physicians were at that time experimenting on a Black woman. But the city commissioned a sculptress, a Black sculptress, Vinnie Bagwell, and she designed a different statue to put in the place of the one they tore down. Next slide. And this is the one that now stands in that spot where J. Marion Sims' statue was. It's called Victory Beyond Sims, and it's actually the facial features of one of the slaves that Sims bought and experimented on. So the community made a difference. Next slide. There's also the history of sterilization of women of color. They were so frequent in the South, they used to call them Mississippi appendectomies. It became a euphemism. And notice the date. The last sterilization was in 1974. So obviously, women who came in with gynecological problems, they weren't even trying to find out what was wrong with them. They just sterilized them as a means of keeping the population intact. Next slide. And it happened with Latinas as well. In the 30s and 1970s, 1/3 of the Puerto Rican female population of childbearing age underwent forced sterilization, the highest rate in the world. When I travel around the country and I work in the Latino community and I speak to women, they know this story. They have that deep-rooted mistrust of the system. Next slide. And of course, we know about Henrietta Lacks, the Black woman who died of ovarian cancer, but whose cells seemed to live on. And those cells were used without permission from her family to perform multiple experiments and were contributing to the research for cancer, AIDS, and other viruses, and even the polio virus. Again, without her permission, and again, abuse of personal consent. Next slide. And we all know about the Tuskegee study. This was a metaphor for research abuse, where for 40 years, Black men, illiterate Black men in the South, were put into a study that they were told was going to talk about the treatment of syphilis, but it really was to watch how syphilis would progress in Black men. Egregious. No consideration for the penicillin that was discovered in 1947. It wasn't even offered to these men. So what happened? 100 died from syphilis. 40 of their wives got syphilis from their husbands, and 19 children were born with syphilis. Deep, egregious experimentation on people of color. Next slide. In 1997, President Clinton apologized. He brought the survivors, there were only 8 still alive at the time, and apologized on behalf of the country. He said, what has been done cannot be undone, but we can end the silence. They now have all passed away, the survivors of the Tuskegee syphilis experiment, the longest running experiment on human beings in modern history. Next slide. And it was going on in Guatemala about the same time. They were deliberately infecting people with syphilis and gonorrhea to see whether penicillin would help solve the problem. Next slide. And in fact, they sent prostitutes and others who had gonorrhea and syphilis into prisons to infect people. This is a picture of a female psychiatric subject who was exposed to syphilis 3 times. While Tuskegee denied care, the Guatemalan study gave people the disease, sanctioned by the U.S. Public Health Service, sanctioned by physicians. Is it any wonder that people of color are reluctant to be involved in clinical research? Next slide. When these documents were unfound or were discovered, Ms. Sebelius, who is Secretary of Health and Human Services, U.S. Public Health Service, and Secretary Clinton apologized. But too little, too late. The damage had been done. Next slide. So what do we have? From Dr. Sims to Tuskegee to Guatemala to sterilization, widespread, deep-rooted mistrust, distrust of clinical research, of physicians, of Western medicine, of the U.S. healthcare system. Do you blame them? But unfortunately, this mistrust and distrust is now coming to work against us. Next slide. So that this was a headline in the New York Times because so few Black and Latinos volunteered to be in clinical research. The statement coming from the community is, I'm not going to be a guinea pig. It runs deep. It's formidable. But in the living with MS, we've got to hopefully educate people to have a change of heart. Next slide. And here's why.
I'm very excited to be involved in the first clinical trial that is focused specifically on MS in African American and Hispanic Latinx people here in the U.S. What we plan to do is look at a disease-modifying therapy for MS and try to look at outcomes such as the relapse rate in this group, as well as disability progression and other measures of disease such as MRI outcomes. We hope to understand how MS behaves in this group and to try to tease out some of those differences that may be due more to biology versus those that are due to socioeconomic status. The ultimate goal of research about MS in general is to improve the care for everyone living with MS. When we look at specific populations such as the African American and the Hispanic Latinx communities, we hope to understand why we see worse outcomes in these groups, and hopefully by learning something about these specific groups, we will gain applications to not only improve their care, but improve the care of the whole MS community. MS does manifest differently in the African American and Hispanic Latinx communities in a variety of ways. First off, when we look at the age of onset, Hispanic and Latinx people are thought to develop MS about 3 to 5 years earlier than their white counterparts. Then if we begin to look at things such as the risk for MS, in African Americans, they are thought to be twice as likely to develop MS, while Hispanic and Latinx people have about half the risk of MS as their Caucasian or white counterparts. When we look at other factors such as how the disease progresses over time, there's more severe disease burden as well as more disability in both of those populations. And then finally, when we look at mortality, the African American community is thought to die earlier of MS, possibly because of more disease burden at an earlier stage of the disease. What I would like to convey to the MS community is that your voice matters. This is an unparalleled time in the field of MS because we have so much more understanding about how the condition behaves, and we have so many more options to be able to effectively treat MS. Our goal is for everyone to live their best life with MS, and in order to do that, we need to increase the diversity in research. So I encourage everyone to stand up and be counted in any way that you can.
So my message to all of you is that race, culture, and community are critical components to address in everyone living with MS. It's about cultural competency, and becoming culturally competent is a journey. It's not a destination. It's not something that you can achieve by one session or reading a book or having one program or one webinar. It's a lifelong process, but it's a moral and ethical imperative. It's no longer an option. We're living in this multicultural mosaic when we have to be able to address the unique needs and concerns of all ethnic groups, especially those living with MS. Next slide. So it's not just about cultural sensitivity. That means you know not to use the N-word. That means you know what may offend people. It's more than that. Cultural empathy, it's walking in somebody else's shoes who not only will be of a different race or ethnicity, but who on top of that are living with MS. It's about safety. Do I feel safe expressing my culture with you because of the style of my hair, because of the clothes that I wear, because of how I speak? Do I feel comfortable, if I can't speak English fluently, of still engaging in a conversation with you? But more importantly, in my view, it's about humility. Your culture is not better than another. It's just different. So being humble and open and receptive to culture. It's about humane medicine. And it's also about where you are on your level of cultural proficiency. I had the privilege of being a founding member of the National Center for Cultural Competence out of Georgetown University Hospital. And we spent a day figuring out where people are. Destructive, maybe those are the people that we know are not in this group, the Idi Amins and the Hitlers and the ethnic cleansers. Incapacity is when it's really hard for you to understand what it's like for me to live in my skin because you haven't been around people who look like me. Only thing you know about people who look like me is what you get from the movies or on TV. Or maybe you're culturally blind. Maybe you're somebody who says, I don't see color. Well, yes, you do. I want you to see my color, to respect it and to celebrate it. Yes, we're all part of the human race, but we also have different races to be celebrated. Openness is MS Views and News having this kind of forum, talking about a very difficult topic, a very controversial topic that makes people uncomfortable. Cultural competence means we got it. We know what the research is. We know how to work with people of different cultures. We know how to embrace them and bring them into our fold. That's what we really want. And cultural proficiency means that's the top of the mountain. You've achieved it. You not only embrace culture, understand culture, but you celebrate culture. Next slide. When I was a little girl, like many of you, when you were young, you played with these crayons. And I was always confused by that beigey pink crayon they call flesh colored, because it didn't look like my flesh. Well, you'll be happy to know, next slide, that the company that makes those crayons took them out of the box. They now have a line of crayons they call skin tones that go from apricot to ebony. Well, I'm in the box now. So if a crayon company could adapt to the different cultures and colors of the world, how much more so can we adapt to the race, culture, and communities that are making up a part of this beautiful mosaic we have in this great country? Next slide. So March 11th, the pandemic was declared last year, and the health disparities became glaringly apparent. About 2 months later, an African-American man by the name of George Floyd, 36-year-old man, was brutally murdered on the streets of Minneapolis. Both of these incidences have brought us to where we are today. The importance, the urgency of eliminating racial and ethnic health disparities. Next slide. And as Martin Luther King Jr. said, we just celebrated his birthday last month. When you talk about social justice, when you talk about health disparities, listen to what he says. Injustice anywhere is a threat to justice everywhere. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one affects all. Whatever affects one directly affects all indirectly. Next slide. So after all we have discussed today about race, culture, and community, and the challenges of living with MS, here's my plea to you. Here's my hope and wish for you to embrace quality, affordable, accessible, culturally competent, equitable healthcare is not a privilege. It's a civil right. It's going to take all of us, each one of us, to make a difference for all of us. So we embrace, celebrate culture. We recognize the problems. We recognize the challenges, but we are resilient as a people, as a country, and we want communities to embrace and celebrate culture. Next slide. Muchísimas gracias. I thank you for your attention. I hope that this was informative and it would help you to see how race, culture, and community impacts living with multiple sclerosis. Thank you.
Sheila, thank you so much for this wonderful presentation. It's powerful, and it's necessary, and it's impactful, and we are extremely grateful for that. Thank you. We do have some questions from the audience. if you want to do it. We have a little bit of time. Everyone, again, if you are able to see the question box where the orange arrow is, you're welcome to send in some questions for Sheila. I'm going to start, Sheila, with this question. What barriers to healthcare are currently being addressed on a national or local level?
There are barriers, and I think, Jennifer, you and I have talked about that. There are systemic barriers with the healthcare system. There are provider barriers with healthcare professionals who don't necessarily appreciate culture and know how to work with it. And then there are cultural barriers, the patient barriers, feelings that we individually have. I can say for sure that people are now beginning to address the systemic barriers. How can we change policies and procedures in healthcare institutions to make them more welcoming? With regards to the personal barriers, that's something we have to come to terms with ourselves. You know, how we are going to address our condition, be voluntary to get in clinical trials. And that's a very difficult hurdle to go over, but it has to be addressed, as the doctor said in the video that you saw. In terms of the healthcare system, we have to empower patients. MS Views and News does a fabulous job of getting information out to people that they can use when they talk to providers, when they talk to their families. So all across the board, there are efforts being made. Is it enough? No. Do we need more? Yes. So inch by inch, we can accomplish the goals that we want to achieve health equity. But the good news is people are already waking up to the need to do that.
Thank you, Sheila. I do have another question here. Are there disease communities working within other disease communities to address systemic racism?
Yeah, I've seen more of that. I know for sure that the American Heart Association is now joining forces with the American Diabetes Association. So they're kind of collaborating on the diseases that, that are related to each other and impact each other. I'm not seeing enough of it in other disease states. And I think that may be a question of resources, both human and financial. There's so much that many of these not-for-profit organizations can do. So they're trying in some ways to collaborate and to bring partners in that are not the usual suspects. I'm hoping to see more, but I'm beginning to see people at least talking about it.
Good to know. It's good to know. It's a good question. I have this question. How can we get more minorities involved in our communities?
That's also a difficult one because there's such mistrust and distrust. The majority population makes a good effort to reach out. But unfortunately, because of the historical abuses, they're very suspicious, they're very skeptical. And so it's going to take time to develop a relationship. It's like making a friend. What does it take? You communicate. You try to be a part of that person's arena. You eat in their restaurants. You go to their events. You can't do it as a me, us, and them situation. You go to their churches. I mean, you have to inch by inch. And of course, with the pandemic, all of that's very difficult right now. But even with technology, to reach out to these groups and say, I want to learn more. I want to understand more. I'd like to be a part of talking to you about things that I'd like to do, if it'll work. It's just about conversation. It's about building relationships.
Yeah. And we have, just want to say, Miss Dixon from Columbus, Ohio. I love this program. Thank you. I have another question. Is there a way, or do they understand the how African Americans are treated with MS and how it affects them?
Do they understand? Who do you mean by they, do you think?
I'm not sure. I'm thinking from a clinical perspective, the differences in how treatment impacts African Americans.
I don't know that it's well known. I think by virtue of the fact that the MS community is so many people unfamiliar with the community, it's not as widely known as it should be. I think it needs to be something emphasized in medical schools and in residency programs. It's got to be something that's put on the agenda. It's not necessarily one that people focus on, but we need to have training. In fact, 15 states now require cultural competency training as a condition of relicensure. So now physicians are being compelled to learn about and understand different cultures as a significant factor in their treatment and their diagnosis. So we need more of that. We need more education, more understanding. And quite frankly, as I work around the country, I find that people want to do the right thing. They just don't know how. And so we've got to make sure that we have an open forum to talk about hard things and difficult subjects, but we've got to make sure that the education, cultural competency is a part of multicultural, is a part of medical education.
It's crucial. Thank you. I wanted to share some feedback. I got, wow, she is amazing. Muchas gracias from Belinda. I've got, oh gosh, I've got Ari, Jamaican, my lady, very informative, and thank you from Diana. And excellent from Jill, and a lot of gratitude coming your way, Sheila.
Oh, that's nice. I'm feeling the love. I'm feeling the love, Jennifer.
It's really good. It's really good. And we're just happy that so many people have joined us tonight. And we're very grateful to be able to have the opportunity to do this with you, Sheila, and with everyone on the line. We thank you for participating in tonight's program. And this is a 4-part series, so you're in part 1, but I want you all to know that next month on March 18th, we will be back with Sheila for a conversation about Black and African American experience with MS. So exactly. I hope that you can all make it. If you're signed up and registered for this, you don't have to sign up again. You're registered for the whole series, just so you know. And we want you to also know that you're going to receive a survey once this webinar closes, and we really value your feedback. We'd love to hear your comments, questions, and experience with going through this whole process, because it is it's a process and it's an emotional experience to go through this with Sheila. And we're very grateful that you're all here with open hearts and open ears. And it's really great. So thank you very much, Sheila. And we hope you enjoyed the program.
It's my pleasure, and be safe and stay well, everyone. And I look forward to March 18th. Thank you, Jennifer.
Thank you.